Good afternoon, everybody, depending on, or good morning or good evening, depending on where you're joining us in the world. This is our MECI Alliance seminar series, our weekly engagement with the community as our students and our faculty and our partners continue to do work from the comforts of their own bedrooms and homes. It's a way to continue to engage intellectually and understand the vibrant work that our faculty, that our students, that our partners are doing. Today it's my great pleasure to introduce Professor Ellen Roche, Professor of Mechanical Engineering and in the Institute for Medical Engineering and Science, who will share some of her work in integrating organic components with synthetic soft robotics, a paradigm shift for preclinical testing of implantable devices. We'll give Ellen the floor and we'll hold questions to the end. We can use the Q&A functionality at the bottom of your screen, and we'll take the questions in the first come, first served order. So with that, Ellen, thank you for joining us today, and I'll turn it over to you, and as we'll glitch for a moment as we switch to your screen sharing.
Thanks so much, Brian, and thanks, Teresa. Thanks for organizing this, and thanks for giving me the opportunity to present. It's a pleasure to share some of our work with you. I'll share the screen here, and we can get started. One second. All right. Does that look good to everyone?
Perfect. Very good.
Okay, great. I'm hopeful for a full hour without any toddlers running into the room, but we'll see how that goes. So today I wanted to talk about some of our work on integrating organic components with synthetic soft robots. Just to give a brief overview of the work that we're doing in the lab. This is my group, the Therapeutic Technology Design and Development Group. And here is just some schematics of some of our outputs from the last while. I'll speak to you a little bit more about some of those in detail. Sorry. So an overview of my research. Our research is in four main areas: mechanical assist devices to augment organ function, mechanoresponsive therapy delivery, dynamic organosynthetic simulators, and in silico models. The approach we take to these areas is to utilize soft robotic implantable devices to augment organ function. And a lot of our work to date has been on cardiac function specifically. But we also use these soft robotic approaches to modulate the immune response for delivering different types of therapy. Using these same approaches, we are trying to reanimate organic tissue for benchtop simulators to act as test beds for testing these implantable devices, and also as tools for improving training and teaching. And these are the areas that I'm going to spend the time speaking about today. So I'm going to talk about our organosynthetic simulators and how we are combining these synthetic robots with organic tissue. So why do we want to do this? So this coupling organic tissue with soft robots is a little bit of a crazy idea, and you know, it's kind of creepy in some ways. I know when we published a recent paper, people referred to it as this Frankenstein heart. But there's a lot of reasons why we're doing this. The first of them is that there are limitations in current models for device testing. So here I'm focusing on the heart. And for devices that are implanted in the heart, intracardiac devices, for example, prosthetic valves or occluder devices, as well as stents, there are a number of models that companies or research groups use to test these devices. Including, as you see here, pumps that replicate the hemodynamics of the heart. On a second, there is an anatomical model that recreates the kind of tortuosity of the vessels to get a device to the heart and the anatomy of the heart itself. Computational models that try to simulate the environment of the heart, and then ex vivo models where an explanted heart is connected to plumbing to kind of try to recreate the environment. All of these have limitations, whether it's that they don't recreate the anatomy or that they're based on a lot of assumptions, or that they recreate the anatomy but they don't recreate the mechanical environment of the heart. For ex vivo hearts, it's very complicated to try to test while the tissue is still viable, or at least while the tissue maintains its mechanical properties, and it's quite cumbersome to set up the setup each time. So there's really an unmet need for dynamic physical models that preserve anatomic features but simultaneously recapitulate biomechanics for high fidelity testing of these intracardiac devices. So we want to take kind of the best features of each of these models and combine them in a benchtop setup that has anatomic fidelity, but also allows us to recreate the biomechanics in a tunable manner. Another reason that we're trying to couple this organic tissue with soft robots is that there are limitations in current models for teaching and training. And here I've focused more on the respiratory simulators. So there, again, are computational models that allow you to input different parameters. There are models that are meant to recreate the lungs, but it's basically kind of a box where there's no visualization. You don't really know what's happening inside it. Or there are models that use organic tissue, but are very limited in the amount of tunability and in replicating disease conditions, for example. So again, there's an unmet need here for dynamic physical tunable models that preserve anatomic features while also mimicking the mechanics, allowing visualization and allowing simulation of disease conditions controlled by the user. Finally, one of the main motivators of why we're doing this is that there's an absence of multi-system models that replicate mechanics and their interdependency. So for example, for the cardiovascular and the respiratory system, there are very few models that link the two of those together. I show here a very basic anatomical model that has the lungs and the heart, but it doesn't really have a lot of function at all. And then a virtual reality simulator, which I thought was just funny. This surgeon is saying I accidentally ripped his lung out, but obviously these are very limited in what they can achieve. So one of our main drivers is to really replicate the cardiovascular system, the respiratory system, but combine the two of them together and to allow us to investigate their interdependency and how one affects the other. So we have this vision to create an organosynthetic thoracic simulator. This would consist of organic components shown here on the left, as well as synthetic biomechatronic soft robots, and we couple them together. I'll talk about how we're doing that at the moment. And overall, we want to build this thoracic simulator that has organic lungs that are moved by a synthetic robotic diaphragm and a hybrid heart. And the hybrid heart consists of organic endocardial tissue, or the inner tissue of the heart is organic preserved tissue with a soft robotic matrix that's driving the motion of that tissue. And this would be connected to a mock circulatory loop, and we hope to replicate the hemodynamics of that loop. Of course, this model would be highly instrumented, so we could measure things like flow into the lungs, pressures in the pleural cavity and the abdomen. We could also measure flow and pressure at different parts of the heart and in the rest of the vascular system. So the merits of this type of system is that it's an excellent teaching tool. So if you can visualize these processes happening, it's very useful for students to develop that model of how things are working. It's useful for testing medical devices, particularly the biohybrid heart, where you can put intracardiac devices in an environment of pathologies. It helps people to understand different disease conditions, and it really allows a system in the cardiovascular system which has a lot. So I'll break down the talk into first an organosynthetic model of respiratory physiology. So first up is led by Clara Park, who is a Mackey graduate student. So basically what we want to take a 3D advanced magnetic resonance imaging called architecture. So how do the muscles or the cardium bottom of the left-hand column is to inspire is the entire heart. So this is an preserve to maintain its the special dissection technique. You can it's called the myocardial helical ventricular band. When you unwrap this, now you have a 2D structure, and you can take that structure and scan it using the same imaging techniques, this diffusion tensor imaging, and that allows you to use a technique called tractography to identify the orientation of the cardiomyocytes in that structure, and that's the main muscle of the left ventricle. And using that structure, we can create a flap pattern of a soft robotic matrix that then can be rewrapped around a heart with this muscle removed from it, and integrated into one component. We can actuate that active muscle using pneumatic actuation, so we can move the entire structure in the way that a heart would move, and we can recreate myocardial biomechanics that way. So that's kind of a lot to imagine, and I'm going to take you through kind of the steps to achieve that one by one. So first of all, we take an organic heart, we fix it, and then we figure out a way to protect the atria and the vessels, which are the upper components. And then we cast an outer mold around the lower myocardium so that we have a really good replica of the geometry or the physical structure of the ventricles. We keep that outer mold. Then we take the heart and we start with this dissection process, which allows us to really dissect along the direction of the cardiomyocytes. So we remove all the myocardium from this structure and leave as much as we can just the endocardial components. Then we want to figure out if we can combine this organic tissue with a synthetic matrix. And here for a start, we're just looking at a passive synthetic matrix, not a robotic myocardium, just a silicone synthetic myocardium, and how we would join or integrate the organic tissue with this synthetic myocardium. So we go back to our original mold and we place the dissected heart in the mold and use different methods to center it in there. And then we can cast silicone around the void left between the dissected heart and the outer mold. So we get an exact replica of the myocardium in silicone. We can disassemble those two, and then we use an adhesive that we developed in collaboration with Professor Zhao in mechanical engineering, which allows us to integrate this silicone myocardium with the organic endocardium. So we end up with a biohybrid heart that combines both synthetic and organic tissue. This is passive, it's not active. I'll talk about how we make the active one again, but just to give you an idea of how we make one structure of those two components. The development of the adhesive was critical to achieving this. We came up with an adhesive called TissueSil with Hyunwoo Yuk and Professor Zhuangyi Zhao. And what we show here is how the TissueSil really interpenetrates into the myocardium. It's shown in green here and allows a good bond between them. And if we look at CT imaging shown here on the bottom, the heart is shown in red and the TissueSil is shown in yellow, with the synthetic myocardium shown in orange. And if you look at the cross sections with the adhesive in yellow, you can see that it's really good conformability between the synthetic and the organic tissue, and they're bonded together with this TissueSil adhesive. This also allows some flexibility of the entire structure, so that when you move to an active robot, that the adhesive itself doesn't hinder that motion. So this is what the biohybrid heart looks like. We're looking at this from a long axis view, so taking slices through the heart. The soft robotic myocardium is shown there in a darker gray, with the organic tissue in a lighter color. And we'll also go from a short axis view. This is down from the top of the heart. If we're moving through, you can see the left ventricular and right ventricular chamber. The organic tissue is in a lighter color than the rest of the synthetic tissue. Sorry about the background noise. Here's what it looks like when we unravel the heart. So this is literally unwrapping the heart into a flat band, step by step, and we can take the areas of interest that form the left ventricle and scan those on their own, because really what we're interested in this work is recreating the motion of the left ventricle, which is the chamber that pumps to the entire body. So we take that section and we use diffusion tensor magnetic resonance imaging. This gives us a 3D map of the orientation of the cardiomyocytes. We locate the epicardial or the outer surface of the heart, and we can project that data onto a 2D plane. And we use a technique called tractography to allow us to identify the orientation of each of these muscles, because the orientation of the cardiomyocytes is critical to the functioning of the left ventricle. From this, we can map out a coarse grid of orientations of these fibers. We can translate then that to a soft robotic band. Here we're using a type of actuator called a flat pleated artificial muscle. Basically what it is a number of chambers that can be pressurized with reinforcing linear structures. That means that when we pressurize them, they contract axially. We use this type of actuator because it's very flat, so you can wrap it around the heart afterwards without taking up too much space, but it mimics the contraction that the heart achieves with every heartbeat. We also can look at finite element model of the band to predict how much this is going to contract and to optimize the layout of how many actuators we place. So when we reassemble this, when we wrap this flat band around the organic tissue, we then put it in the outer mold, like the process I described for the passive heart. We put the active heart back into the mold and assemble the two together using silicone. So we have one holistic structure that can be actuated with pneumatic actuation. When we do that under echocardiography, you can see the motion that we achieve. This is the inner chamber of the heart. And you can see as you go through the heart cycle, from systole, which is the ejection stage, to diastole, the relaxation stage, there's a difference in the chamber volumes. I'm going to play that again. This is a biorobotic hybrid heart, and this is what it looks like at the end of the relaxation phase on top and the end of the ejection phase on the bottom. This, in comparison, is an in vivo reference heart. And you can see the similar motion as it's beating. It achieves this reduction in chamber volume. So we're getting towards a situation where we can recreate or reanimate a heart to achieve some of the cardiac motion. It's not perfect yet. We have some way to go in order to achieve the hemodynamics that a native heart does. But we definitely are able to reduce the chamber volume in a similar way to the heart. So this is what it looks like in still images, a long axis view. This is when it's depressurized. And then when you pressurize it, the stars here show the inflated soft robotic chambers. The same from a short axis view. So you can see the reduction of the chamber. We can also model this in finite element to show the reduction of the chamber from the relax stage to the ejection stage of the cycle. And you can see the reduction in that volume. So with this work, we published this work earlier in the year in Science Robotics. We were able to successfully couple the synthetic active myocardium with preserved organic tissue, and we were able to recreate myocardial motion. The next steps here are to recreate the hemodynamics, specifically the pressure volume loop in the left ventricle, and to attach this heart to a mock circulatory loop. We're also looking at coupling this soft robotic matrix with decellularized tissue. At the moment, we're using fixed tissue, and we'd like to move to decellularized tissue, which will allow us to move towards a total artificial heart. And we're part of a consortium called the Hybrid Heart Consortium, which is, the group is currently a finalist for the British Heart Foundation Big V Challenge. And the goal of this consortium is to create a total artificial heart using soft robotic muscles with a decellularized or tissue engineered endocardium that can replace a heart for patients that are waiting for transplants. Okay, I'm going to move to the next section of the talk. So this is an organosynthetic model of respiratory mechanics. This is mainly Marcus Horvath and Lucy Hughes' work. They're two grad students in my group that are part of the HST MEMP program. The vision here is that we would recreate respiratory mechanics by using a soft robotic synthetic diaphragm. This is a mock-up of what the entire model looks like. So we have a thoracic cavity that's separated from an abdominal cavity by a synthetic diaphragm, and that diaphragm is moved by pneumatic artificial muscles or soft robotic actuators. The merits of this, or the utility, are that we can use it for teaching. So it's a good pedagogical tool. It's very nice for visualizing the motion of the lungs in response to diaphragmatic motion. I teach HST 100, which is respiratory pathophysiology, and we've used this model for teaching in that class. It's also useful as a training model for mechanical ventilators. And as an in vitro test bed for testing devices that are used for either lung sealants or for bronchoscopy or for biopsies and things like that as well. So this is the realization of the model from kind of concept to what it looks like in the lab. We have acrylic compartments to represent the thoracic and the abdominal cavity. We have a synthetic diaphragm that's moved by these artificial muscles, and we can put organic lungs into the upper compartment. So when the diaphragm moves in response to actuation, these lungs will expand as happens during inspiration. What's nice about this simulator is by using different pressure inputs to these pneumatic artificial muscles, you can tune the resulting pressures in the thorax or the pleural pressures in the abdomen. So you can get different degrees of inspiration and expiration, mimicking shallow breathing or deep breathing. This is a video of the simulator in motion. So you'll appreciate as the diaphragm moves down, the lungs can inflate. You can see that we have incorporated a window here, which allows us to vary the compliance of the abdomen. And we can also vary the mechanical properties surrounding the lungs. I mentioned the tunability of this model. So with different pressure inputs, we can achieve different tidal volumes. So the tidal volume is the amount of volume that's that is inspired and expired with each breath. So by using different pressure inputs to the soft robotic actuators that are moving the diaphragm, you can achieve different tidal volumes into the lungs. You can also achieve different pleural pressures. There's a negative pressure in the thorax, which helps to breathe, and you can achieve different degrees of pleural pressure by using different pressure inputs to the pneumatic artificial muscles. I mentioned that we can vary the compliance of the abdomen. We have this window built in, which has a silicone structure with a retractable polyurethane window. And by changing the degree of opening or closing of that rigid polyurethane window, we can change the overall compliance of the abdomen. So we can go from a higher compliance to a lower compliance, and we can observe measure the effect of that compliance on both the abdominal and the pleural pressures in each of the cavities. Similarly, we can look at varying the compliance of the lungs. So we can surround the lungs with different structures to vary their stiffness or their compliance. And this is useful for studying different disease conditions where the compliance of the lung changes. So by changing the stiffness of these lungs, you can generate different curves. So the flow into the lungs changes, and also the volume that the lungs fill to and empty changes. And you can do this real time. You can measure both the flows and the volume in the simulator. Similarly, you can replicate different disease conditions. So this is 3 different types of pneumothorax. This is when you get air between the lungs and the pleural space. There's 3 different types of pneumothorax, and they differ by the relationship between the pleural pressure and atmospheric pressure. And each of those can be recreated with this simulator model to show its effects on the flow, on the volume, and on the pressure. So this is a really nice teaching tool to help students to understand the difference between a closed pneumothorax, an open pneumothorax, and a tension pneumothorax, where the pressure in the pleural cavity is actually greater than the atmospheric pressure. Each of these have different clinical effects, but to understand the mechanics and to visualize them is really nice. We also looked at using this tool to close a pulmonary leak. So we took the lungs here, we created a defect in the lungs. With that defect, you could observe the effect this had on the pleural pressure and on the tidal volume that was going into these lungs. With the 275 medical device design class, one of the teams developed a device that would seal the lungs after an injury to the lungs. And we used that catheter-based device with the mesothelial patch to seal the defect in the lungs. And then we could measure the function of this. So how much did it change the function after resealing a defect? So what you can see here is if you look at the pleural pressure, after puncture, basically you're losing your negative pressure with the red line here. With each breath, you're losing that negative pressure. But after sealing, you can restore or maintain some of that negative pressure compared to what the case was before. Similarly with tidal volume, after puncture, your tidal volume is decreasing with each breath you take, so you're getting less and less volume into your lungs. But after you seal it with this pleural patch, you can maintain your tidal volume from breath to breath. So this is a nice demonstration of how you can use this model to evaluate devices. Finally, and this is probably topical at the moment, we can use the simulator to test ventilators. So we connected the simulator to a ventilator, and we could measure basically the flow and the pressure with our simulator and show that it corresponded to the ventilator flow and pressure. We could also do more than the ventilator could. So the ventilator can't measure the pressure in the chest cavity or the pleural pressure, but we can do that with our simulator. So that's kind of a nice additional piece of information to have. We could also show that the simulator itself could trigger the ventilator. So, you know, because the simulator was autonomously breathing, this could trigger the ventilator for expiration and inspiration, which is a nice function of it. Okay, so with this simulator, we were able to replicate breathing mechanics of different pathological tips or to replacing stents, a moxotic cardiovascular. Finally, we are also ventilator for patients that have model will be very beneficial for a therapeutic strategy. A case study where we combine, this is called the Fontan, important for the certain disease condition to the system and the respiratory system. So this is a project that's he has been assisted by David Van Story, who's working with Dr. Pedro Del Nido, who's the Chief of Pediatric Cardiac Surgery at Boston Children's, to help people with a condition called HLHS, which is hyperplastic left heart syndrome. These kids are born with one ventricle that's severely underfunctioning. So as you can see here, the left side of the heart is not formed correctly. So they have a really small left ventricle and a number of different complications. This is a really serious condition, and it requires multiple surgeries before the children are even age 5. So pretty much in a healthy physiology, this is the left side and the left side and the right side of the heart, and how the blood pumps oxygenated, how the heart pumps oxygenated blood around the body from the left side and deoxygenated blood to the lungs on the right side. And this is what the vasculature looks like in a healthy physiology. With these patients, the surgery that they undergo ends up with a physiology that looks something like this. So the one functioning ventricle that they have pumps oxygenated blood to the body, and the return to the lungs of deoxygenated blood for subsequent oxygenation is passive, and it's done through a cavopulmonary shunt. So this isn't active, and it's reliant just on passive return to the lungs. And this is where we are interested in developing a device to help patients that have this physiology to improve their quality of life and a lot of the resulting comorbidities that go along with having a physiology like this. So we started out on this project to develop a device, and we quickly realized that we need a really good environment in which to test this device. And the environment can't be just a simple flow loop. We need to recreate the pressures, the breathing pressures that have a huge influence on the flow in this type of physiology. If you imagine this shunt is sitting in the thorax, so it's very dependent on the breathing pressures that are generated cyclically with respiration. So this is a boy called Judah. His parents have kind of created a website of his journey with Fontan surgery, but I think it's you know, very sad. These kids have 3 surgeries. The first is done within weeks of their birth. It's called the Norwood procedure, where they have a little shunt that connects some of the vessels here. I won't go into all the details on this, but about age 6 months to 1, they have another surgery called a Glenn procedure. And there they connect the superior vena cava to the pulmonary artery to return to the lungs. And the final Fontan procedure occurs when they're about age 5. And basically this inferior vena cava is connected to the pulmonary artery to achieve that passive return to the lungs. So this is all sitting in the thoracic cavity, and the effect of breathing on it, like I mentioned, is very critical. So what we've done is we've incorporated a model of this Fontan. When you reconnect these, you get what's called a Fontan cross. And we've recreated this Fontan cross in our breathing or respiratory simulator so that it can be subjected to the pressures that occur with respiration. We've also added different compliance chambers to replicate abdominal compliance and lung compliance, so that as the diaphragm moves, the changes in these compliance are mimic what happens in the Fontan physiology. So when we connect, this Fontan cross is based on patient data on an MRI scan, and we can recreate that with 3D printing methods and integrate it into the thoracic cavity of this respiratory simulator. With these compliance chambers, we can also achieve the compliance in these different chambers, and we can put flow through this vascular loop. So here on the right, we see with this pink fluid, this is where the blood would flow through this system. And we can tune the pressure of these different components using Windkessel models or chambers of varying heights. So we can pump the blood through this. This is a video that shows the moving of the diaphragm and its effect on fluid movement through the cavity. There's some air in the system here, but it allows you to visualize how this is happening. So if I play this, you can see as the diaphragm moves, you get these changes to the flow that's happening in these vessels. And what we could do was we could mimic or replicate Fontan flow that has been reported in the literature. So this paper was published in Nature Scientific Reports last year, and they tracked the flow in the inferior vena cava, or in that shunt, where that shunt would be. And we were able to mimic that with this simulator. So follow the curves that happen with one breath. And with that, then we can look at the effect of varying things like breathing magnitude, and how does that affect flow in the inferior vena cava. So like if a shallow breath compared to a deep breath, how does that affect the flow? How does varying the breathing rate affect the flow in the inferior vena cava? How does varying the compliance of different vessels affect the flow? And these are insights that are difficult to elucidate in patients, but with this model, we can tune things and understand this interdependency and hopefully come up with improved therapeutic strategies for these patients. So the conclusions of this part of the work are that we replicated Fontan hemodynamics, and especially their interdependence with the respiratory pressures. And the next steps are we want to validate this entire flow with a Fontan patient MRI, and we're collaborating with with our clinical collaborators at Children's Hospital and beyond to obtain these MRI images from these patients. And we want to use this test bed eventually to evaluate devices we're working on in the lab to improve this failing Fontan physiology and give these children a better quality of life. So I'll finish with this for fun. We had an exhibit in the Science Gallery in Dublin of our respiratory simulator. There was an exhibit called Plastics, which was highlighting the advantages and disadvantages of the use of plastics in our current life. This was, again, Marcus Orvath was leading this with Luca Rosalia, a grad student in my group. And I'll just play this for you.
This is a respiratory simulator and a biohybrid heart that mimics one of our setups in the lab. We use it to test medical devices. In the bottom, we have soft robotic muscles that pull down the diaphragm, and pulling down the diaphragm drops the pressure in the chest on top that expands the lungs and sucks in air from the top, just like we breathe. Plastic has been used in prototyping medical devices, in surgeries, as well as in a lot of implants that we're using today. The bottom part is made out of acrylic plastic. Then we have thermoplastic polyurethane as a membrane coated with silicones. And then the top is polycarbonate and real lungs attached to that from the pig, and a real heart from the pig as well. It also meets the person as how we are reflected in plastics, and we're turning into plastics, but in a more life-giving way. And people can stand in front of it, push the button, and take a breath together with the real lungs that are inside of it.
Okay, and with that, I will finish up, and I wanted to thank my funding sources that have supported this work, and obviously my fantastic team without who this work would not be possible. So thank you for your time, and I'm happy to answer any questions you might have.
Ellen, thank you very much. I send the virtual clap here. So participants, please use the Q&A. And I see we already have one question in from Alex Benjamin. It's actually a three-part question. The first part is, how much information is lost when the 3D DTI data is projected to 2D? And I think this was in the heart.
Yeah, that's a good question. Yeah. So for that work, we actually scanned the 2D unwrapped tissue. So, you know, it was a projection into 2D, but it wasn't like, I think the amount that was lost was pretty low there because it was pretty much a flat structure when we scanned it. If that's your question. I don't know if you can unmute yourself or.
Teresa, are you able to unmute Alex Benjamin so he can? He may have.
That's okay.
Okay.
I mean,
I don't think he's here anymore.
Yeah.
Okay. So, yeah.
Okay. Yeah.
So the second part of the question was, how does the robotic band setup mimic muscular anisotropy?
Yeah, again, so we unraveled the heart into the helical ventricular myocardial band, and then we scanned that and used those orientations to create this soft robotic band. So it should mimic that band pretty well. And then we rewrap it in the same configuration that would have been the case for the initial wrapping. So it seems like maybe the point that we scanned the unwrapped tissue was missed.
Let's see. A third part of the question, which is also a question that I was going to ask, or related to it. What is the mechanism for timing the contraction and relaxation? And the parenthetical that I would add to that is, not being an expert in this area, the human brain, I don't think, implements PID controls. But what are some of the novel opportunities that could be available for developing sort of biomimetic, brain mimetic control systems to complement the structure and the mechanics?
Yeah, it's a great question. Right now we can input the, so for both the heart and the respiratory simulator, they're pneumatically actuated, and we can input the pressure that, you know, whatever pressure kind of waveform we want into those actuators to achieve either the cardiac cycle or the respiratory cycle, and we we can tune that, or, you know, increase the rate, decrease the rate. But there are a lot of interesting opportunities. For example, you know, can we have kind of closed loop feedback there? Can we have another project where we have a cardiac sleeve, and there we sense the native heartbeat and synchronize the actuation with the native heartbeat. So potentially we could measure somebody's heartbeat and replicate that in the model. Same for breathing rate. You know, you could sync it with measurements from a person and have it tuned to replicate their function. But also I think, yeah, potentially you could measure some other parameter and have a feedback loop so that you're increasing or decreasing your cardiac or respiratory rate according to some other measured parameters.
Very nice. So we have a question from Farhad Nazami. With the heart model, is there any plan to also include the afterload and how it would affect the heart function and PV loop?
Yeah, absolutely. Yeah. So, you know, as I mentioned, the next step is to kind of attach this heart or connect it to a mock circulatory loop. And in that loop, we would have preload, afterload, you know, and we could modify them accordingly.
And we'll take one more question here from Albert Musa. For the biorobotic heart, you used pneumatics to produce motion. Are piezoelectric transducers an option in doing that?
Yeah, absolutely. I don't think that we're limited to pneumatic actuators here. I think there's a lot of different actuator types that could be used for actuating this. So that's a good suggestion.
Very good. So with that, Ellen, again, thank you very much. I send the virtual clap. Again, thank you, participants. And Teresa, if you can bring up the slide just to advertise for next week. As everybody knows, this is a weekly seminar where we cycle through students and faculty and external collaborators to really give you a vibrant picture of the types of work that are happening in the department and in collaboration with the department. Next week, we'll hear from Lauren Chai, who is a doctoral student in mechanical engineering, on her very interesting work in using acoustic techniques to assemble materials during the manufacturing process with applications in wearable technology. So Lauren will be next week at 12 o'clock, same time, same channel. And then this is going to be an ongoing seminar. Even when we reach a post-COVID, if we ever reach a post-COVID world or a sort of a new normal, this is a great way to continue to highlight the phenomenal faculty, phenomenal students, and phenomenal collaborators that we have. So please, if you're interested in presenting, do send us a note, and we'll work to get you sort of trained on sort of the best practices, if you will, and integrated into the speaking cycle. So with that, I thank you for your time. Enjoy the rest of your day. Again, Ellen, thank you very much.
Thank
you. Mechie Alliance Seminar Series signing off for today. Have a good day, everybody.
Thanks so much.